Back again for another exciting lecture. Well, neurological imaging, chapter 19. I'm just going to preface by saying that some of this information in your book is old because helical scanning and 3D reconstruction have replaced some of this information, but I'm going to go ahead and present it anyway so that you will know some of the historical and what we're talking about, and then I will try to point out more current things here. So if we just look at routine scanning, um, just some general notes on scanning of what we would do. We're always going to do a reference image, but you know that already. We're going to do a scout, and if we're doing head or spinal scout, well, this is neurological imaging, we're always going to do a lateral or a side view picture. It might be called a scout image, it might be called a planogram, it might be called I can't think of the other names off the top of my head, but I'm going to call it the scout image that looks like the x-ray. Always we're going to get a lateral scout image when we're doing the head or the spine, head, neck, or spine. We commonly do an AP scout also, but that is not usually as useful in setting up our parameters. We usually want to use the lateral scout. Um, this is general information that we will do almost any scan that we do. You're going to enter positioning information into your protocol. Let me say that many of you may have a protocol that says routine head or trauma head or cardiovascular imaging of the head. This information will already be inputted in there, but someone at some time had to set up this protocol. So this is information that you're either going to put in or that is in your protocol. It's going to have let them know if the patient is going in head first or feet first, because that makes a difference if it's the right or the left side you're viewing. It's going to have the information if the patient is prone, supine, or decubitus. Again, this is usually pre-programmed. Almost always the person goes in head first and they're going to be supine, but that is not always true. If we're doing something other than our routine, we need to be sure that we have these parameters set on what we're doing. And so some of the scan parameters that we're going to be using, the MAS, we're almost always going to have that floating MAS that it changes the MA station as you scan. We will have a set KVP, and the field of view is usually going to be set in your protocol. Scan field of view for a head is usually somewhere 25 centimeters or 250 millimeters. Same thing. And then where the algorithm, whether you're scanning on a high resolution scan, or if you're setting on a bone algorithm, or if you're scanning on a soft tissue algorithm, those are going to be programmed in, but someone has had to put them in at some time. Annotation of contrast, IV and or oral. Well, we're usually not going to give oral contrast if we're doing anything in the spine or in the head, but we are going to give IV contrast, not every time. And as you know, you're going to notate on there somewhere that IV contrast is being used. Repeat scans of contrast and non-contrast should be done at the same scan location. What I'm saying here is if you do a pre-scan and you have a parameter set up from where you start and stop point and the slice thicknesses, you should do the same thing as you give contrast so that you can match up scan for scan a non-contrast image and a contrasted image at the exact same location. So that's what they're talking about when we say repeat. It does not mean you did something wrong. It means if you're doing a non-contrast and then a contrast, your parameters should match up. Excuse me. Obviously, we're going to obtain a history for patients and things that we need to know about that patient. We will either get it verbally from the patient or from something written. And exact and precise instructions should be given to the patient on holding still, what you're going to do, and what's going to happen. Again, that's just good patient communication. If we just look at a little bit of history in our original scanning, CT is phenomenal. It has brought us into a modern age, and the modern CT is a total different animal than the CT that I did in the late 80s, early 90s, because that was before helical scanning or volumetric or fast scanning even existed. So a little bit of history. Before 1972, any information that was obtained really inside the brain was from a pneumoencephalogram. That is just what it sounds like. You did an intrathecal injection, you did a spinal injection, and you put air in the below in this in the subarachnoid space, and you took some cerebral spinal fluid out and you injected air in. What it did, it filled up the ventricles, and even on this general x-ray that you can see, a lateral x-ray, you can see the lateral ventricles. They're superimposed here, but you got an idea that these ventricles were of normal size and shape. It did not tell you anything about the soft tissue, but if you had a tumor here that was pressing on this ventricle, or if this ventricle was greatly expanded because of hydrocephalus, then you could have seen that that was something going on. Very rudimentary, but you had some view. You also could do a nuclear medicine scan. I mean, you could also do a nuclear medicine scan here. We don't even do this anymore. I'm also a nuclear medicine tech, but you would do scans and the radionuclide would show up if there was a tumor. Again, it wouldn't just show the soft tissue itself. It would usually show if there was an area of increased activity, which usually was um, malignancy, or area of decreased activity, which is where the brain was dead. And so it was very rudimentary, but we had that. And then we could do an angiogram. Here you can clearly see that there's an aneurysm here. So this would be a carotid angiogram with the anterior cerebral artery and its branches going here, and the middle cerebral artery coming out here to the side, in the middle of the head. This is as if we're facing the patient. So this would be looking at their nose here in the midline, and then out to the ears on the side, which would be the middle cerebral artery. And so we could see that. Again, it does not show us the brain tissue itself, but if there was a huge tumor here, it might, in the brain tissue, it might shove all these vessels out of place. So we're looking for displacement, basically. This is that pneumoencephalogram machine. I never used it, but I did see there was still one in the hospital where you put the patient in this chair. You could do AP views and you could do lateral views. So you didn't have the C arm, but you had a machine set up. So you turned the patient in different positions so that the air rose to the anterior part of the ventricles, or we turned them upside down so that it rose to the so that it was at the posterior part. You could turn this chair right or left so you could feel different things. So basically these stayed in the same plane, but you turned the patient around. It looks like some kind of torture chamber to me. So why would we do some? What are some indications for head, neck, and facial scanning? Well, trauma is a very real one. I work in the trauma center here in Houston at Memorial Hermann. It's a level 1 trauma center, so we see the bad trauma here in the city. So CT is great because it can show bone and soft tissue, air. You get a good picture of everything, whereas MRI is not so good at showing bony structures. It is great at showing the brain and the connective tissue, but not good at showing the bony structures. So, and there's a lot more prep to do an MRI scan. I have to do a lot of more patient information about what they may have had, what kind of implants they might have, or if they're coming in from trauma, they might have pieces of metal or gravel or other things on them that we couldn't scan. Whereas in a CT patient, all of that stuff, it may make a little artifact, but it is not going to damage them. So it is a great, CT is great for trauma to show everything. We can use CT to show inflammatory processes if we have abscesses in the brain, and also in the face, sinusitis, where you have sinus infections. It is great for that. We do very few sinus x-rays in the areas where I work now. Uh, I think we could do more, but we usually send the patient now to get a CT scan of their sinuses. Congenital abnormalities, that means something that you're born with. That AV, that arterial venous malformation, where you have an abnormal connection way between the arteries and the veins in the brain. Sometimes this doesn't exhibit itself or demonstrate itself until later on in life. And then hydrocephalus also, that is when you have an increased amount of CSF in the ventricles or in the brain. Yes, we do operations to drain that, where we put a catheter in to drain that into the abdominal cavity, but we follow them so we can do it. That's a congenital disease that the child was born with. It can develop later in life from obstructions, but most often it's a congenital disease. Cerebral bleeding, we know that we certainly can do that to try to see any kind of bleeding in the brain. Endocrine studies, well, that's going to be looking at the pituitary gland. CT is great for looking at the sella turcica, the bony structure, the sphenoid from the sphenoid bone that houses the pituitary gland, and then also to see the pituitary gland. Follow-up studies might be used to see the gland itself with an MRI. tumors of any kind, primary tumors, either benign or malignant, and metastatic lesions all through the brain or the spinal cord. And a neurological dysfunction. Well, we can't actually see seizures, but we can, if a person has seizures, then we would scan them to see if there is any physical evidence of why they're having this, if there's a tumor pressing on something. Whereas if it's seizures, uh, uh, then we may not, if epilepsy, we couldn't necessarily show that, but we would rule out other things causing the seizures. And then the CTA, the CT angiography that we can use now, that's taken over a lot of the original angiographic studies, where we can actually look at the arteries all through the brain. So just some general imaging information. We should immobilize the patient's head. Obviously, we should immobilize the patient anytime, but especially when we're doing the head scanning. Slashes should be parallel to the supraorbital meatal line to reduce radiation exposure to the lens of the eye. I'm going to ask you that on a test somewhere. Anytime you see something highlighted in yellow or red, you can be pretty sure I'm going to ask that again. We still would like to duck the patient's chin so that that supraorbital meatal line is there, or we can angle the gantry. Yes, nowadays we do reconstructions, reformations of the images once we've gotten them, and we can put any kind of angle or slant on there we want to. That does not reduce the radiation that was received to the eye. In general, if we could give less radiation to the lens of the eye, the better we are, because radiation to that lens can cause cataracts. This is why we do this. Some protocols may call for images to be taken in the direct coronal plane. I added, your book didn't say this, I added not very often or never, because we can do multiplanar reformation and in any plane or an oblique plane, and it is as good as if we have our voxels are cube shaped, we do not lose any resolution. They're just as good as the original axial images. So we have the ability to reformat those in a different plane. And so I don't know that we ever do those in the direct coronal plane anymore. In my early days of CT, when our reconstruction algorithms were very poor, we did images in a direct coronal plane. If you're doing it either supine or prone, or change the angle, or change how the patient is lying or entering the tube, the gantry, be sure to input the correct orientation before scanning, whether they're supine or if they're going in head first. All those things still matter. Because of the density of the skull, of the bones in the head, especially the petrous ridge, it is very tense and next door to small, up against very soft tissue. If you've ever seen a real brain or touched a brain, it's kind of like gelatinous. And so you have a very dense object with a very not dense object in the middle. So we have beam hardening artifacts. We have talked about beam hardening artifacts in a previous chapter. That just means we get these streakings because we got disruption of the signal, because you're going through a very dense object to a very not dense object. Because of this dense bone structures, you get beam hardening artifacts. They're most often seen in the posterior fossa, which is where the densest bone is. So thin slices can help reduce these artifacts. We also have artifact reducing algorithms that we can apply that will help clean up that, but you do lose a little resolution on the images also when you clean up the artifacts, but you get a better effect if you get some of those artifacts out of the way. Those artifacts, beam hardening artifacts, are not something we can eliminate. We can just try to lessen them. Routine head studies can be done using the step-by-step method or the axial mode. Seldom is this done because we almost always do a volumetric or a helical scan. Uh, but you can do an axial mode. As you remember from some of our previous chapter, the absolute best resolution is when you do a single slice thickness. You don't lose any resolution, but you lose time and you lose other things, and it's not very good for reconstruction, for 3D reconstruction. You need the axial mode. So we seldom do that. It would be more likely if there was a very specific area that you had to have the highest resolution, that you might do the step-by-step scanning. The helical mode is used primarily for everything that we do because we can do 3D imaging, and we have to have it if we're doing CT angiography to see the vessels lighted up. So we'd have to have it for that. Um, because of there's a very small because of the small differences in attenuation in the brain tissue itself, the gray and the white matter, they're almost the same density. We are usually going to film the brain at a rather narrow window width. And again, we talked about window widths and window levels in another chapter. That just means we're going to have our highest and lowest. Our window width is going to be fewer steps. If we say the window width is 500 steps for an abdomen, it might be 200 to 250 for a brain. Because if you have a more narrow window, it highlights the differences between the gray and the white matter. Because if not, they blend together. And this is just a picture kind of saying what I've already said about that supraorbital meatal line. So we would like for the scan to go here so that it does not go through the orbits. So you don't want to go straight across here through the orbits. Uh, so the can be scanned single slice, not helically. Be Head axial scans, you can do it single slice. Gantry tilt to the supraorbital meatal line. If the patient can't duck their chin to get this down, then you would angle the gantry. Um, on this, we might on the CSF is going to appear dark in the cisterns and in the ventricles because the CSF is not dense. So we expect to see dark areas in what's called the cisterns or in the ventricles. A cistern is just an area of collection of the CSF. Calcium may appear in the choroid plexus. That the choroid plexus are cells that line the ventricles, especially in the posterior horns of the lateral ventricles, and we can see those the choroid plexus, those cells sometimes calcify and they show up as bright even when we don't give contrast. Also, they can light up. The choroid plexus also absorbs contrast. It's one of the places where we cross the blood-brain barrier, and they may light up a little bit more. So that's normal. We might see a calcified pineal gland and the falx cerebri. The falx is the dura that we see dividing to the right and left hemispheres. It is dense enough that we would normally see with no contrast. We might see a calcified choroid plexus, a calcified pineal gland, and then that white line going down that's the falx cerebri, especially in the upper images of the brain. The white and the gray matter, seeing the difference between the white and the gray matter allows for definition of basal ganglia, the thalamus, and the external and internal capsules. If we're doing certain studies, we may need to be able to recognize the basal ganglia so that we can see if there's something going on there. And so this is the differentiation of the gray and the white matter, where the basal ganglia and these things are. We'll look at that in a second. So this is an example of dark and light structures that we would normally see in the brain. This is a brain that does not have contrast, but we see these calcifications here and here. That is a calcified choroid plexus in the lateral ventricles, and this is a calcified pineal gland. We know that the pineal gland calcifies in some people. It is not pathologic. We know that the pineal gland has a little bit to do with our sleep-wake cycle. And this is a good example. This white line here, that's the falx cerebri. That is totally normal. It's dividing the brain into the right and left hemisphere, and it's dense enough that it shows up. And everything is good. This should be a straight line down here. We don't see a mass effect. A mass effect is when we have something shoving. It doesn't necessarily have to be a mass. It could be a bruise, but a mass effect means that things are shifted on the midline. But here, that falx cerebri is completely midline. So this is a traumatic bleed with edema. So at different levels, this is just edema, the black part. The brain has liquefied, and it basically is fluid in the brain now where the tissue has died. It probably came from this bleed that the person had. And so now we do have some contrast in this one, but you've contrasted that, and you can see that this is the brain bleed, but this has been bleeding for a long time because this brain has dissolved. This is an example of bleeding, just of a recent bleed into the brain here, in the intracranial, the tissue inside the brain is bleeding here. So that white is bleeding here. The white here is bleeding, and the black is where the brain has dissolved. I put this in here at different places in your book and at different references. It's going to give you different Hounsfield units or CT numbers, but this is just so you can get an idea. You can see that the gray and the white matter is very close in its density, and it overlaps a little bit, which is why sometimes If you don't use a narrow window, it is hard to tell the gray and the white matter apart. The cerebrospinal fluid is basically zero because water is zero. This is just a little bit more dense than water, so it's gonna appear dark in the head. Circulating blood is 40 to 50, whereas clotted blood or blood that's bled out is 60 to 110, and that's why we don't want to give contrast, or we don't need to give contrast if we're looking for a bleed. That clotted blood will show up dense itself, as almost as dense as contrast material. Uh, Tissue calcification, well, any kind of calcification can be very calcified or not so calcified. So this is just some general numbers for that. Fat, remember that fat is less dense than water. So if you had some kind of fatty tissue in the brain, which you wouldn't see very often, or some kind of fat deposit, it would be less dense. If we did an ROI, we would see that it is less dense than water. And air, well, we shouldn't have free air in the brain tissue itself, but we should see air in the sinuses. We should see air in some of the facial structures, and so it should be somewhere about 1,000, a minus 1,000. Again, anything less than water is going to have a minus number. Anything water or above will have a positive CT number. Some of the things that we look for a lot in injuries are intracranial hemorrhages, ICH. And so we'll classify those as three different types of hemorrhages. So CT is the most commonly used initial examination for imaging for intracranial hemorrhage because, again, we don't have to screen the patient. We can bring the patient right in, no matter where they've come from, what condition they're in, and do a CT scan. We will get a good idea of what's going on. The appearance of the intracranial hemorrhage will change with the passage of time. A fresh bleed is going to be hyperdense. As it dissolves down or goes over a period of time, it's going to become less dense. It will become isodense as the brain, and then when that brain tissue dies, it will become hypodense, less dense than the brain because fluid will fill in. So as the general rule, the ICH, the intracranial hemorrhage will appear hyperdense to the normal brain tissue for the first 3 days. Hyperdense, then you will get a hyperdense center. It's still dense in the center, surrounded by concentric areas of hyperdense and hypodense tissue. So this clot starts dissolving, and so on the outside, and so you're going to get less density on the outside, but a hyperdense center. After a while, it will become isodense from 11 days to 6 months, and this is really variable. And then hypodense to normal, it will be hypodense, less dense than the normal tissue after 6 months. That's why sometimes when a person has a scan, the doctor will say we see evidence of old stroke because the blood has dissolved or that brain tissue has died, so it may have little spots all through the brain of where you have hypodense, where you have less dense areas where the brain tissue has dissolved. So this is a schematic of what I've just said. So the white is showing hyperdense, that means fresh blood, isodense, the same density as the brain tissue, and then hypodense, less dense, because now then the brain has kind of dissolved, necrosis, and then necrosis has taken effect, and this has just been filled in with fluid. So it less than 7 hours, we're going to see this bright bleed here. It may continue to grow over days. Usually less than 7 hours, you might not see it, or you barely will see it as it starts to bleed. Then over 7 hours to 3 days, it may increase in its size. After the bleeding stops for anywhere from 4 to 10 days, you start getting the center is going to stay dense, but you start losing density on the outside. And this is just going to, as this tissue then dies, necrosis, it's going to just be absorbed, and it would just be fluid filled around here, and then this starts getting normal brain, and then after 6 months it will just be a blank spot there. So it goes from hyperdense to isodense to hypodense. So if we talk about some different types of hemorrhages that we could see, and I'm going to ask some of these on my test. So recent hemorrhage, a recent brain hemorrhage is going to contain hemoglobin. Hemoglobin is why it's going to show up brighter on the CT image. The recent bleed is going to appear as a density on the CT due to the protein that's in the blood, that hemoglobin. We don't want to give contrast if we're looking for a hemorrhage or a bleed. On the trauma, we do not give contrast to start with. We want to see if there's bleeding into the brain. So over time, the hemoglobin is removed and the image loses its density, and it would go back, just like we saw on there, back to the same density as the brain. So to start with, for trauma or suspected bleeding, we do not want to give contrast. This is the three divisions. Your book didn't go into this as much as I did, but I thought this was important from just general knowledge and from scanning myself and seeing scans done. We can have an epidural hematoma. The dura is the outer covering of the brain, that dense fibrous covering. It's kind of leather-like. So if we have an epidural, that means it's on top of or outside the dura. It is between the bone and the dura. So it's a collection of blood between the bone of the skull and the dura. Tends to show a mass effect. In other words, as you get blood between there, it shoves the whole brain to one side or the other, so you see a shift in the midline. Um, it does not cross the sutures. The suture lines, those little where the skull, different parts of the skull, the frontal, the temporal, and the occipital bones, all those where they come together, the dura attaches there. So if it's attached there and it's outside the dura, then it can't go past a suture line. Then if you have a subdural hematoma, it could be acute or chronic. Acute is going to show up quicker, but you can get chronic subdural hematomas where the patient doesn't know it, bleeds over a period of time. They might start losing some function and it gets worse and worse and worse. They might be a little confused to start with, and then later on to get to where they're maybe completely comatose. So acute hematoma, subdural hematoma is what we're talking about. It's a high density collection of blood between the dura and the brain itself. So it's subdural, it's below the dura. Well, then there is the arachnoid layer, a cover of the brain, but it's very soft, and so you're going to see this hematoma blood going into the little crevices on the the gyri of the brain, the gyri and uh, oh, I can't think of the other word here. I need to brush up on my anatomy, don't I? The yes, the fissures of the brain on the outside edge. So it follows the contour of the brain and has variable amounts of mass effect. In other words, you may have a little effect where it shifts the brain from the right to the left or left to the right, but not usually as much as you do in the epidural hematoma. And then you can have an intracranial bleed, which might be called a subarachnoid hemorrhage. Uh, this is bleeding into the brain tissue itself, most frequently caused by a ruptured aneurysm. May show increased density blood in the cisterns and the ventricles. So you may see bleeding throughout the brain that may collect it may displace some of the CSF or be in the CSF, in the ventricles, and in the cisterns of the brain. The sulci and the gyri. That sulci was the word I was trying to think of, the little indentions in the brain. So if we look at what an epidural hematoma looks like, so we can't see the dura here, but if we get a, if we, so it's almost, there's just a potential space between the dura and the skull. But if we get bleeding here, so that would be the dura coming here, it's a tough fibrous covering like leather. So it is not bleeding into the brain tissue, it's between the covering of the brain and the skull. So that's the hematoma. The bones here, the hematoma, and the dura going here. So you can see that you get a shift. That's called the mass effect. It's really shoving the brain over to the side. It's shoved it way over here. And it's completely closed. It's so much compression that it's completely closed this ventricle off here. So we get a mass effect. So the blood is between the dura of the skull and the dura, and here you can see it. You can see that's the dura, the covering here, and that's that epidural hematoma. So it's going to have a nice smooth border because it's got that tough leather covering over the brain, and so it's going to have that nice blister or convex appearance. Most often, this happens with a skull fracture, maybe of the temporal bone, and bleeding from the middle meningeal artery. I don't expect you to know that, but a skull fracture can cause this. It stops at the suture lines because this dura is attached to anywhere there's a suture line. That's where it attaches to the skull. And so if it's attached here, it can't go past that because, well, it's attached to the brain, to the skull itself. So it does not it stops at suture lines, and it has this effect. I would be able to recognize that as an epidural hematoma. A subdural hematoma is when you're below the dura, so that tough outer covering is out here, and so you just have the soft tissue of the brain. So it's going to follow more along the brain, the edge of the brain, and it's going to be more linear. Also, it can cause suture lines because the dura is attached here, but it's below the dura, so it can cross here. But it should stay in the same hemisphere because remember, we have this falx cerebri here dividing the brain into the right and left hemispheres. So it can cross suture lines, but it stays either in the right or left hemisphere. Now, you could have a subdural bleed in both hemispheres, but this bleed here should not cross over here because there is the dura that comes down, as you can see, comes down here and divides the brain into the right and left hemispheres. So bleeding between the dura and the brain tissue, usually no skull fracture. This is usually something bleeding from internally. It can be chronic, where you have a small bleed and it just bleeds over a period of time and the patient doesn't know it. And you may see where they've had old bleeds here and then it's gone away. They may have been um, not symptomatic or very low symptoms. It can cross suture lines but stays in one hemisphere. It's more linear shaped, as you can see, and it may fill these little fissures of the brain here because it's going here. So it may have more of a ragged appearance because it's going into those little indentions in the brain. And then we have the intracranial hemorrhage, whereas it's bleeding here in the middle of the brain. Most often, this is from a hemorrhagic stroke, a hemorrhagic cerebral vascular accident, where you get bleeding out into the brain. And you can see now it's out into the ventricles, it's out into this lateral, the posterior horn of this lateral ventricle, it's in this lateral ventricle here, and it's just out in the tissue. So most commonly from CVAs or commonly called a stroke. Also from aneurysm. Again, an aneurysm is going to be where you have a ballooning of the artery and it's going to break and it's going to bleed out, which is a type of stroke. But the stroke was from an aneurysm, from a ballooning of the vessel to start with. So you can see blood vessels here and they bled out into here and they're just causing bleeding out everywhere. We might do something called a perfusion study. There are different places that do these. These are usually to try to demonstrate if there has been a lack of blood flow to an area. So it is a quantitative study. A qualitative study just says that I can see, well, a qualitative, I can see that this is more dense than this. But how much more dense? I can't put a number on it. So if you're doing a qualitative study, I can just say, yes, this is more dense than this. If I'm doing a quantitative study, giving it a direct number, a quantity, then I can tell you. So here we're looking for slight differences in perfusion, how much blood gets to this area. Now there's numerous ways of doing this, but any perfusion study is looking at how well the brain is getting blood flow to a particular area compared to another area. So quantitative data can be extracted from the maps by placing multiple ROIs, like they've done here, in the brain parenchyma. So I can tell it should be perfused, or blood should be going equally to all these areas. If I've not had a bleed out, and if I've had a bleed, I can probably see it. But maybe I have slight occlusive. Instead of having a hemorrhagic study, I might have an occlusive stroke where I get a clot from a blood clot or from plaque or something else and just stops the blood flow. It doesn't bleed out. It just stops the blood from flowing. And so I will not get as much perfusion. So you give the patient contrast and then you do this particular type of study. Again, let me say there's numerous ways of doing this, but the whole objective is to compare different areas of the brain to see if it's getting the same amount of blood flow. I'm going to measure that blood flow by giving contrast, and because then I can measure the number of the contrast. So if we look at this one, this is a pretty even because it's looking at ROIs. And if you can see the number, this is number 1, this is number 13. I don't know why they're in such strange orders. 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2. Oh, I guess this is 1 and we're going I don't see 2. I don't know where. Well, they don't have a 2, do they? So they're looking at these ROIs. The numbers, the CT numbers are about the same. This is the ROI, and this is the number that we're giving. The size of these is about the same, and this is the size, and then it would give a reading of what the CT number is on each one of these. And if one of these is greatly reduced or much greater than another area, we could say that it is being perfused differently. So perfusion is just looking at how well the blood flow is to the brain. When I said earlier, this perfusion study may look at the area of where the basal ganglia are here. These outlined these outlines here are showing where the basal ganglia. This level is most frequently scanned for brain perfusion studies. The outlined areas of the images are the basal ganglia. So in this one, this is the basal ganglia. And we're looking at the basal ganglia, we're looking at what might be the different layers there of white and gray matter. In your anatomy class, you've talked about those. And so this is just showing you the area of the brain that the ACA is the anterior cerebral artery, the MCA is the middle cerebral artery, and the PCA is the posterior cerebral artery. This just shows you the areas that these particular arteries perfuse. So if you had a blockage in the anterior cerebral artery, we would see less perfusion to this area. And the same thing for the middle or for the posterior. Uh, that you're going to look at particularly. Coronal sections, again, this is a little bit old information because we are going to do reformations on all brain studies in the coronal plane, but it's valuable. The reason the coronal plane shows us, it can show us scans for the roof of the orbit and the base of the skull and the cranial vault. It lets us see the orbit outline better than axial studies. Because we're doing the axial studies, we're not seeing the whole orbit at one time. Coronal images of the temporal bone can show the relationship of the ossicles, the inner ear structures, and the structures along with the medial walls of the middle ear and window, the oval window, and the lateral semicircular canals. What I'm saying here is if we're looking for inner ear structures, if we're looking for structures in the inner ear within that petrous bone, those ossicles of the brain or the semicircular canals or the cochlea, then a coronal image is going to show them better. We do not have to scan in the coronal plane. We can reformat those in the coronal plane because the modern machines can do it just as well as a direct scan. Coronal images aid in showing whether a lesion is either super or infra the tentorial area, so we can see if it's above or below the tentorium if we do coronal images. This is an example of a coronal image, which is you're showing where you can see the whole sinuses outlined here, artifacts and fillings in the teeth, but it just gives you a different presentation by doing a coronal plane. Again, the coronal plane here is showing the inner ear structures. And if we were doing for inner ear structures, we would probably do reformat, reconstruct in a different DFOV and make this very large so that we can see these little inner ear structures. But a coronal image gives you the coronal images, more than one image is going to give you the best view of the inner ear structures. Here, I think this is an MRI, but it's demonstrating what we're seeing is that in the coronal plane, you can see the cerebrum and the cerebellum, and you can see that where the tentorium would go. So you can see if something was above the tentorium or below it, because if the tentorium is that part of the brain lining, the dura that separates the cerebellum from the cerebrum. Here we can see it in the sinus area, in the orbit area. We can see if there's things going on here. We can see a great amount of fluid in the sinuses here, and so that's really going to show us very well when we do coronal images for the sinuses. Sagittal images, your book says they're not routinely used for brain images. A lot of the places where I see are where our students go here in the Houston area, at least, which is what I'm familiar with, that they automatically, because it doesn't cost anymore, you're not doing on film, it just may take a little more time, but it's so automatic now that sagittal planes are usually done also, even though it said it was not usually done routinely. You will just see in your own place whether they use that or not. But it's good for facial images, temporal bones, and for the sinuses again. It can show that. It's helpful in evaluating anything in the midline structure. Is it going past the midline or a shift? Okay, so now we'll go back to those very first things we talked about. What do we use as CT? Well, we've already said that we use CT and trauma. It provides information about contusions, bruising, like in this case, you don't see any bleeding, but the brain has swollen and you see a midline shift. If you drew a straight down line here, so you can see bruising. Now, later on, there may be some subtle bleeding here that will show up, but initially that brain has been bruised and looks like there's a little indentation there, so for a midline shift. Hematomas, blood clots, we can see this subdural hematoma here, it going along here, so we can see that. inside or outside the brain. We could see an epidural or subdural or inside the brain. And also we can see the bony fractures. Now, there obviously is going to be brain damage here, but we can do this. We don't do skull x-rays on many of these patients because we can see already the fractures, and then we can do a 3D reformation to see the cranium in a better fashion than you could with general skull x-rays. We can look at inflammatory diseases. Again, an abscess from an inflammation. An encephalitis is the inflammation itself. It can show if the brain is swollen on one side, and then especially in an abscess, typical for an abscess, you're going to see the wall of that abscess is going to highlight, and then you may see necrotic where the brain has dissolved around it from that old abscess. So this is the abscess, and then the brain around it has dissolved and become quite liquid. This is very typical of a brain abscess, a bright ring around this. Donut shaped, low density center, and enhanced rim. That's what we're saying here. And then you can also show swelling. Congenital malformations, I said earlier that the two that we would think about most often is going to be an AVM, arterial venous malformation. It's just where the arteries of the veins make something that looks almost like a nest. When you did this scan here, you can see that there's just a big nest of vessels here. This can cause problems later in life. It's usually there, but sometimes it grows as you get older. And then the hydrocephalus, this is these ventricles are huge, fluid filled, so there's very little brain tissue around this person has very little active brain tissue. That this is a person who obviously did not have surgery and shunts put in to drain this. But this is an example of hydrocephalus, a great exaggerated example. But this is congenital studies we can do. Endocrine, again, that's going to be looking at the pituitary gland. We said that a coronal view is a coronal view is going to show that very nicely, that in that tumor. We also could see this very well from MRI. Um, we also can do it for tumors, malignant or non-malignant. This image here says this is a lymphoma tumor. Could I tell you that's a lymphoma tumor? No, and neither could you, because you'd have to do a biopsy to know what kind of tumor it really is. Excuse me. So you could show tumors that are malignant and non-malignant tumors. We're going to talk a little bit more about those in a second. Um, you can have a cerebral infarction, which is a stroke. Here, I just show one that is a ischemic, where the blood flow has been blocked, but a hemorrhagic stroke would show it would be also it's called a stroke, but a hemorrhagic is where it bleeds out. An ischemic is where the artery is blocked and you don't bleed out, you just get decreased blood flow, and then that tissue that doesn't get blood is going to start dying pretty soon. And then after this says 24 hours, that tissue has died, you get that tissue death, and then later on this will just turn to basically fluid because that tissue is dead. But if it's a hemorrhagic stroke, you would see if it was bleeding out, you would see blood all out here, and the tissue is still going to die. So so for a ischemic stroke, initially produces edema in the area of the ischemic brain tissue, followed by necrosis or cystic changes. So here, this is 4 hours that you have got decreased blood flow. Now, if you did the CT scan and you didn't see any bleeding, then you might follow up with a contrast image to see if you could do an arteriogram, and then they might send the patient on to MRI to see that brain tissue better. But we're proving here that that they didn't have a bleed, and then we did this to start with. They didn't have a bleed, so then we may follow it up with a contrast study, a CVA, but we still see our calcified pineal glands, and we see calcification here in the choroid plexus of the lateral ventricles, which is totally normal. A meningioma, I'm just pointing out some of these that your book pointed out. It is a benign intracranial tumor. As you might guess, it's a tumor that grows off of the meninges, over the covering of the brain. If you're going to have a brain tumor, have a meningioma. They're quite treatable. I knew a young x-ray guy that had a tumor that was at least this large, and he had it a surgery while he was in x-ray school. He did just fine, but it needs to be taken care of. It is not malignant, but it can come back. It's growing on the meninges, so A meningioma is you're going to see it along the edge of the brain because that's where the meninges cover. Here it's growing off the meninges, it's not growing in the brain tissue itself. So it's the most common benign non-malignant intracranial tumor. Arises from the dura adjacent to the inner table of the skull or the edge of the skull. It's usually vascular and it enhances when we give contrast. So if we did this to start with and then we followed it with a contrast, it is going to enhance. That is characteristic of it. It is going to get very bright because it's vascular. It will enhance with contrast. These are some other tumors, glioblastoma, any kind of these intracranial tumors are really bad news. It's a glioblastoma is the most common primary tumor of the brain, appears as a mixture of low density enhancing. So you can see here, some of it enhances, some of it's low density. It doesn't quite look like a uh, abscess because it doesn't have that complete nice ring around it, but it's going to look very different. But you couldn't look at this and know that this is a glioblastoma. You would have to get tissue to do slide studies to look at the type of cells that are being done. Prognosis is very poor for the astrocytomas or the glioblastomas. Those are primary brain tumors that have poor prognosis. Metastatic disease, that means that these tumors have come from cancer somewhere else. Commonly, we get mets to the brain from breast cancer. You get mets to the brain from breast cancer and sometimes from liver cancer. Multiple lesions from a primary tumor, usually breast or lung. I don't know what I don't mean to say liver. I meant to say lung. So breast or lung cancer can metastasize to the brain, and usually mets are going to be small focal lesions, and they maybe all over the brain here, because here, when you see multiple little lesions, it's usually from metastasis. Usually, a primary is going to be one lesion that grows, and you can see that this lesion has caused a mass effect. It's really shoved it over the it's push the brain over to one side. Whereas these have not had as much mass effect because they're smaller and they're throughout the brain. Usually seen as multiple enhancing lesions with adjacent edema. So there's edema around that, but there's multiple ones. So that would be indication that it's METs and that it does enhance. Brain protocol, axial most often used. We always scanned in the axial mode. Uh, when we used to have to worry about computer space, we would do thinner cuts in the posterior fossa because of the artifacts from the dense bone. But now then we scan the brain all the way through, either at threes or fives, almost always. But in the earlier days, we did the posterior fossa with 3 to 5 millimeter slice thickness, and the rest of the brain 7 to 10. Almost now we scan the brain all the way through. Probably the standard is 5 millimeter thickness. Thinner cuts for particular things. Coronal images, we've already said it's best for inner ear structures and for acoustic neuromas. This is a tumor on the acoustic nerve, on the eighth cranial nerve. I learned it as the acoustic nerve. I think it's called the vestibulocochlear nerve now if you're studying it with in Miss Lobren's class. Helical scanning which is what we almost always do, is best for all vascular abnormalities, aneurysms, AVMs, anything that's vascular, and we need it to do 3D reconstruction. We almost always do helical scanning. We only do this if we need to see some very particular slices at the very highest resolution. The window widths and levels, a window width anywhere from 100 to 160, maybe up to 200. The levels, remember, the level is set at about the tissue of the density of the tissue we're concerned with. Well, if we look back and look at the CT number of gray and white matter, it's somewhere in this 25 to 40 range. So we're going to set the level at the brain tissue, and then the window width is going to be more narrow if we want to see better highlight between the gray and the white matter. So that's a relatively narrow window width, and the level is somewhere between 30 and 40, which corresponds with the CT number of the tissue of interest. Just some other protocols, and again, protocols are going to be set by your institution or wherever you're scanning. But in general, the temporal bone, because we want to see the inner ear structures, we're going to do the thinner slices there. We're going to use a bone algorithm. This is how the information is processed. Again, we talked about algorithms, I think in chapter 4 or 5. we can do a bone. It's not just uh, demonstrating it in a bone window to view it. We have collected the information, or we have processed the information into a bone algorithm that highlights the bony structures, but it diminishes the view of the soft tissue structures. But we can do a soft tissue algorithm also that we don't see the bone very well. And so we may do it, reprocess it, and use it in both of these algorithms. But many times we're always going to see the temporal bone in a bone algorithm because it is going to highlight the spatial resolution there. We're going to look at axial and coronal images, even though that the coronal images are usually more beneficial to us. Orbits, again, thin slices, and we're going to reformat those into coronal and sagittal. Paranasal sinuses are the sinuses, again, thin slices. Coronal plane is best. We saw that. We can see that the easiest. We can use bone or soft tissue algorithm, or we can use both of those. Neck imaging, I'm not going to say much about this because I don't know that we do neck imaging to see the carotids and to do a arteriogram, and then we do the spine imaging, but I don't know that we call it neck. We would say we're doing spine imaging over the cervical area, but your book puts neck imaging, so I'll say that too. General notes on scanning of the neck. I have never done a scan where they said we want to see the larynx. I've just never done that. I've seen the larynx when you see all those neck structures when you're doing it, but best done with axial cuts parallel to the plane of the vocal cords. To be honest, I don't know where the plane of the vocal cords is, so I am just giving this to you from the book textbook, not much personal knowledge or experience. About the same plane of the cervical disc spaces. So basically, I guess you're doing axial images. I have done parotid glands quite often when I was at MD Anderson. We had to do to get rid of fillings in the teeth because the parotid glands are along the posterior to the ramus of the mandible, and so sometimes if you had fillings they caused a problem, so we had to do angulation. We did not have the algorithms to clean up the streaking, and also we did not have the ability to do 3D when I did those. So probably some of this information is not very current, but it's still in your book. So slightly oblique views to avoid the teeth. If you're doing those, it's usually because you have fillings in the teeth. May need to do two sets at different angles, and we did. We had to do them at different angles because, again, we were not able to do the 3D reconstructions. The neck is usually scanned helically with IV iodinated contrast material because almost all the time when we're scanning the neck, we're doing a CT angiogram. Contrast shows the major vessels. We know that already, the carotid arteries and the jugular veins. It demonstrates submandibular glands and the submandibular glands and the parotid glands. So the parotid gland is the one that we looked at most often because it is most often has a tumor and it's the largest of the parotid of the salivary glands. So why do we do neck and face scanning? Well, developmental abnormalities. Of course, if you have a face that's disfigured from congenital or from injuries, so we can do that. And then we can do 3D reconstruction, sometimes for surgical planning or to do cosmetic surgery. We could do these for inflammation or infection, especially the sinuses. We're talking about the neck and the face. The sinuses are often infected, and so we do quite a bit of scanning for the face for sinuses. We also can do trauma for facial fractures or for foreign bodies in the orbit. Again, we have to worry about MRI if we had foreign bodies in the orbit if they were any kind of metal, but CT it does not affect those. So trauma is going to show any kind of fractures or soft tissue damage. Again, while we scan the face, most often it's for facial fractures that we do it when we do the face or for sinusitis. We would also do the temporal bone then for the internal ear, the structures of the internal ear to see those and to see maybe hearing loss. Tumors, obviously, if there can be tumors in the orbital cavity, to assess the extent of a tumor. Before definitive treatment is begun, they want to see the edges of that tumor. The parotid gland to see if it has tumors in it, and the thyroid gland also to see if it has tumors in it. But now then, we don't do a lot of scanning for the thyroid gland because ultrasound is going to do a better job of that, and also nuclear medicine, it would show the functioning studies. So yes, when we do a scan of the neck, we can see if the thyroid gland is enlarged, but we usually don't scan per se for the thyroid gland. We're going to defer that to sonography and to nuclear medicine. And this is just showing you a thyroid tumor. Now, would I know that's a thyroid tumor? No, but it's just a huge tumor that's around the trachea there. Parotid gland, I probably would guess that because it's way out here in the soft tissue. That parotid gland is at the back of the posterior to the mandible. So that would be a parotid gland that's got some kind of a contrast in it or calcification of a tumor. Orbital tumors, a hemangioma is the most common primary mass in the orbit. It is a particular tumor, and it enhances and affects it enhances with contrast, and it affects the muscles. One of those muscles, the rectus superior rectus and inferior rectus or lateral medial rectus muscles that move the eyeball. It's well-defined round mass posterior to the globe. We're going to look at a picture of that. The sphenoid wing meningioma, again, it's just a meningioma that is around the sphenoid bone, a little harder to see, I think. And chronic sinusitis. Uh, if we have fluid or gunk in the sinuses, they will be opacified as opposed to being nicely filled with air, which would be black. We also can have bone thickening, and you can also see that on a good CT scan that the lining of the sinuses has become thickened, and that can be part of chronic sinus disease. So this is a sinus tumor that has completely obliterated the whole sinus, normally aerated sinus here. This is a meningioma, a little bit hard to see that tumor is along the meninges here, but a great example of a hemangioma. This in the orbital cavity, not in the orbit itself, but you can see it enhances and it's taking over, affecting that muscle on the eye. So I would be able to recognize this. Again, this is opacified sinus. It's just full of gunk. This one has a tumor in the sinus. This is just the sinus is normal in shape and size. It is just opacified because there's fluid or infection in the sinus. And we do those quite often to see this. Spinal imaging, well, we're going to do it for trauma, but we're also going to do it post myelogram to see if there's some problem with the disc. So this would be prior to CT. Spinal imaging was accomplished by a myelogram, where we did a uh, injection into the thecal sac, subarachnoid space, and we put dye in and we turned the patients in different ways. We could not really see the disc here. We can see the disc space, but if the disc was bulging here, we might see it pressing on this spinal. This is not the cord down here. This is the cord, because the cord ends up here about L1, but we can see the CSF mixed with the contrast material mixed with the CSF. And if it's pushing on that column of dye, then we would say that probably they have a herniated disc. But now then we have CT to show it directly and MRI to show it even better. So notes on spinal imaging. The spine is done in the axial or transverse plane, which is what we do everything in. Angulation, we used to do this before we could do reformatting in different planes and 3D reformatting. You might angle. In fact, I did this when I scanned for the disc. Angulation can be done on the axial plane, angling so that follow the angle because of the lordotic curve of the spine that you're parallel to the disc space. Most often used to determine traumatic fractures, MRI is used more often for spinal cord injuries because the CT really doesn't demonstrate the cord very well. It's showing the CSF around the cord. If we put contrast in there, yes, it would show if the cord was terribly enlarged, but the MRI does much more to show the cord itself. CT differentiates the disc from the adjacent ligamentum flava. That's one of the ligaments within the spinal canal. The thecal sac, which is the coverings, and the inner intraspinal fat, which I don't really know about, and the bone. So what we're doing is trying to see if the disc is protruding and pressing on a nerve. Nerve roots are identified as they exit the intervertebral foramina. IV contrast enhancement shows epidural veins. You can give IV contrast if they're looking for increased epidural veins. I have actually never done this, but it can be done. What we're usually looking for, Other than a fracture of the spine and displacement, if we're looking for disc herniation, we're going to do this post myelogram. The person is going to have had a myelogram in the department and dye injected into the subarachnoid space, and then we're going to bring them around and do a CT. We can see spinal stenosis if the spinal space has been decreased, if been closed up, stenosed. Spinal infection suspected around the disc space. This is where we would do that injection, uh, IV injection that would maybe show infection or epidural abscess. I don't think we do this very often. Spinal trauma with the danger of neurological compromise. In other words, if the spine has been fractured, then we're always worried about that it's impinged or hurt the spinal cord or the spinal nerves. So one of the things that we're going to do most often then is we're going to look for disc herniation, and this is going to be our post-myelogram study. The disc herniation most often occurs in the lumbar area. Most common areas are between L4, L5, and L5S1. You can have herniation anywhere, but those are the common ones. In the cervical area, it's between C5, the C5 to C6 area. I have some spinal problems in my neck, and it's the C5, C6, and C6, C7 where I'm getting a little nerves pinched. The disc may herniate centrally or posterior laterally, and we're going to look at that in a second. If it goes straight back, it doesn't cause as much problems. If it herniates to the posterior and a little bit to the lateral, it starts pressing on those nerves that are exiting the spinal cord, and they get pressed between the bone, and that's where you get a lot of problems. You correlate your findings with your clinical symptoms the patient has. Like I say, I have a pinched nerve in my neck. Before I had the MRI, the doctor, from me telling him where on my thumb that it was numb, he could tell me exactly already without scanning where that my nerve was being pinched. Now, to see how much he needed to scan, but clinically he had to match it up. Spinal fractures, obviously, we can see spinal fractures, displacement of the fractures and encroachment of the spinal canal, and the fractures pushing into the spinal canal are easily identified with this. If we look at disc herniation, this is a schematic or a drawing of the spinal of the disc. So you have the annulus fibrosus, that tough outer covering of the disc, and then inside the disc you have that nice marshmallow center, which would be called the nucleus pulposa. So the technical name for a herniated disc is an HNP, or herniated nucleus pulposa. Here you can see that the annulus fibrosa has broken, and we got it protruding out here, and it's going posteriorly, but posterior lateral, and it's pressing on this nerve here. That is what's causing the person the problem. Now, this is the cord in the very middle, but it's surrounded by CSF. So if it just herniates just straight back, while it's pressing on, maybe have a little spinal stenosis, not causing near as much problem as when it herniates posteriorly and laterally and presses on this nerve as it is here, and that's where the pain is coming. If we look here, this is the lumbar area. So this is a little bit of the spine itself, but this is the disc. It's not very dense, and so we can see it should be straight across here, and we can see that it's angled, that disc. I do not see any contrast in the spinal canal, so this may not be post-myelogram, but you can see that disc space, this is disc here, that it's shoving here. It should be the same nice thin across here. It should go like this, and here we see it dipping down here. Here that we have given contrast, because you can see that CSF in the spinal fluid, and the cord is going to be wider and thicker up here. It's going to occupy more of the space, and so here we can see that a herniation of the disc. See how this is blipped in here? It goes down here. That's a disc pressing on this spinal canal here. So that's an indication of a herniated disc here. Makes it much easier to see when you have the CSF here. Some of this stuff over here is that ligament of flava that we were talking about, the connective. And this is that ligament of flava here, that area right there. That is not disc. Examples of spinal fracture. Well, this is a nice spine that is in line with that lordotic curve. This canal going here, the posterior column of the spine. Here we have a fracture, and so now we have indentation, and it's pressing in on this spinal canal here, and maybe even tearing or crushing the spinal cord, certainly causing damage to the spinal cord. And then we can see if we do this bony reconstruction and the bony algorithm, we can see that this bone is broken here. We can see exactly how it's broken when we do a sagittal, and then when we do these axials, you can see where it's bone. So it's a great way to see spinal fractures. We can do multiplanar and three-dimensional reformations, and we do that all the time now, where we do a 3D reformation and we can see fractures and things all through the skull and the face. So some abnormalities demonstrated when we're doing the face, most often in evaluating the craniofacial structures or abnormalities. We can determine if the tumor volume, including the pharyngeal and laryngeal cancers. Yes, you can see thickening in that pharyngeal area and laryngeal area. To see if there's tumors there, used as a surgical planning tool. Well, any CT can be used as a surgical planning tool and shows spinal fractures. Well, we already seen that already. And this is just looking at, here's some more fractures. This is some 3D reconstructions to show the what's wrong, and then you can do surgery planning on seeing how you would reconstruct that. If you've looked at some of the things that they're doing with CT now on the mummies, they can do they can scan what's there, and then they can anticipate or say the shape of the face and how that person may have looked in real life. So we do a lot of 3D reconstructions now for surgical planning, and also for cosmetics. You can see that this spine is crushed here when we go there, and how they might do some repair on that. Contrast agents we're using, IV contrast agents that demonstrate vessels as opposed to lymph nodes if we're doing it in the neck, especially, there's lymph nodes in the neck, and sometimes the lymph node can look like a vessel. If we give IV contrast, then it's going to light up the arteries, and we will know that's not a lymph node. The choroid plexus and the dura mater and the meninges, we said that the choroid plexus are those cells that line the ventricles and that produce CSF. They pick up contrast, so they're going to brighten up when we give contrast. The dura, especially tumors on the dura, the meningiomas, they're going to light up and become bright when we give IV contrast. Scar tissue from recurrent disc herniation, sometimes that gives us an idea of the scar tissue will look different than the herniated disc when we give contrast. This is IV contrast. Intracerebral tumors that break the blood-brain barrier. I've said before that the blood-brain barrier sometimes just says the BBB. Normally, the blood-brain barrier keeps contrast in circulation. It does not get out into the tissue. But if there's a break in that blood-brain barrier, then those tumors are going to light up because the contrast would go into them. Glioblastomas, those primary brain tumors, they do that. They light up, they suck up that contrast, and they light up. So we can use that IV contrast for especially to see those primary brain tumors. And the walls of an abscess, we saw that earlier. Those circular walls, they light up the walls of an abscess. So the contrast agents can be used there. Intrathecal contrast agents are going to show the CSF, and they can show if the disc is pushing or impinging upon a nerve or pressing a nerve. And it also can show the cranial sinuses. If we let the contrast go up into the brain, if we do a Trendelenburg and let it go up into the brain, then we can see the cisterns of the brain and where the fluid is lying there. We don't often do this. Patient prep, with very little is needed in patient prep for the patients that are going to have spine, facial, or brain CTs. We obviously will remove any metallic objects that we can. Fasting is not required because we're usually not giving oral contrast, so we're not worried about the digestive tract. If you're going to give IV contrast, then sometimes we recommend fasting for 4 hours, just because sometimes that contrast makes people a little bit nauseated or ill. And so if they have an empty stomach, they're not as likely to get nauseated. Obviously, empty the bladder so that as soon as you get them on the table, they don't want to get off. Contrast injection requires a thorough history. We already know that. If we're giving IV contrast, we still got to know the BUN and creatinine. Because we don't want to do any kind of kidney damage. Place in a comfortable position. If you can elevate their legs under their knees, do that. And we obviously ask them to close their eyes usually when we do the laser planning so that the laser light doesn't shine in their eyes. We know that thin slices improve spatial resolution. So if it's a small body part, we want to do the thinnest slices we can. We can do reconstruction algorithms in a standard soft tissue, a standard or soft tissue, or bone algorithm, or we can do an algorithm where we have edge enhancement if we want to see the edge of something. The field of view, that's how much we scan, large enough to cover the entire anatomic area. We might do a field of view to cover the entire head, and then do a DFOV, display field of view, smaller to zoom in on a particular object, maybe the internal ear structures, those small uh, bones in the internal ear. Smaller DFOVs give better resolution because smaller pixel size, and we talked about that in an earlier lecture. And to conclude this, what shall I wear to work today? What shall I wear to work? Hope you guys enjoyed this. Hope it helped me talking about it. And I'll be back with you another time.